Go off and remain muted for the duration of the presentation. We will turn participants' video off to minimize distractions. We will have Q&A at the end. If you have any technical difficulties, please message the Zoom meeting host. We would like to inform you that this session will be recorded. Today's live session is accredited for CME credit. All accredited CE information may be found in PathLMS. I will now turn it over to Dr. Oviedo to provide a brief introduction of today's speaker.
Hey, good morning, everybody. Maria Martinez-Lage is an assistant professor of pathology at Harvard Medical School and the program director for the Mass General Brigham Pathology Residency Program and the MGB Neuropathology Fellowship. After completing residency training in neurology in Barcelona, Spain, she completed anatomic pathology, neuropathology, and surgical pathology training at the University of Pennsylvania. She serves as the vice chair of the ACME Review for Pathology and is a member of the TDAC, Test Development and Advisory Committee for Neuropathology with the American Board of Pathology. Beyond her leadership in education, her research interests include the morphological and molecular diagnosis of brain tumors and their immunological microenvironment, and the neurotoxicity of systemic and local therapies with an emphasis on translational and clinical applications. I'm looking forward to this talk.
Great, thank you very much, and thank you everybody for joining today. We're going to talk about the effects of a variety of toxins and therapies on the CNS, focusing on neuropathological aspects. I have no relevant financial relationships to disclose. I will disclose, though, that with this lecture, I aim to cover a lot of information. So you're going to see potentially more breadth than depth. And so it is possible that some people in the audience know a lot more about some of these things than I do. So actually, please feel free. If you hear me say something that is not accurate, please put it in the chat so that we all can learn from that. And then the other disclaimer is that I've used a couple of chapters from the latest edition of Greenfields, one of which I am a co-author on. The hope is that after this lecture, you will be able to analyze the mechanisms of neurotoxicity associated with various environmental and therapeutic agents, that you will be able to recognize the spectrum of neuropathology associated with those, and that you will be able to describe the major features of some of these neurotoxins that we will emphasize. To do that, we're going to start with talking a little bit about mechanisms, and then we'll focus on neurotoxic non-therapeutic agents. And lastly, we will talk about the effects of a variety of therapies in the central nervous system. As you can imagine, there is no way to cover the entirety of potential toxins, but we should think a little bit about, what characteristics of each of these agents is going to help determine their effects in our brain and spinal cord. So first of all, I think it's important to think about a variety of features that involve these exogenous toxins, right? So one thing is, the state of matter. They could be gases, they could be liquids, they could be solids, they could be electromagnetic radiation and other types of radiation. In addition, we could think of toxins as being naturally produced versus synthetic. Disclaimer, I'm not going to talk about any biotoxins today or toxins secreted by organisms. And then the way I ended up thinking about them for this presentation was, toxins or agents that are in the environment or that we can be exposed to in different situations, versus recreational substances that people voluntarily use. And lastly, pharmaceutical products of a variety of classes that you can see here and that we will discuss. Thinking about toxicity and neurotoxicity, I'm not going to focus on the actual immediate effects of some of these toxins, like some of the things that produce dependence and tolerance and that kind of thing. But we're going to think about a variety of potential characteristics that will impact the effect of toxins in the brain. Concentration. It is not the same to have low levels of exposure to a toxin, like, for example, something that's present in air pollution, versus a very hyperacute exposure to large doses of something like a spill, for example. We also need to take into account that chemistry matters, and in some cases, for example, for lead salts, whether the lead is in a form of inorganic or organic salt is going to have a different pathway of involving the brain. Importantly, you are potentially going to be exposed to more than one of these, and in general, multiple substances frequently act in synergy. Or even multiple modalities. For example, we will see with radiation and chemotherapy, for example, the sum of both typically is larger than what we would otherwise expect individually. A person can be exposed to these toxins in a variety of ways. They could ingest, they could inhale them, it could be injected, and it could also be absorbed by the skin. And all of those are going to have different pathways of arriving at the brain. And affecting the end organs. In terms of the neuropathology, it's also important to think about, we're talking in some cases about acute exposure and acute events, and the acute neuropathology versus the effects of an injury that might be chronic in time, or that might have been a punctual event, but then the patient survived or recovered, and then the effects of those at the end of their life is what we might be able to appreciate in an autopsy, for example. So just describing some of the mechanisms that are known to involve these neurotoxicity to the brain. We can start with direct cytotoxicity, and that would be an interference with energy metabolism or protein synthesis or membrane integrity. And a couple of examples include carbon monoxide and cyanide, which are known to inhibit mitochondrial function, in part by binding to the cytochrome C oxidase complex 4. And another example is methylmercury that is known to accumulate in neurons and disrupt mitochondrial function. Oxidative stress can also be part of the mechanism of injury. This typically refers to the increase in reactive oxygen species that then is known to lead to lipid peroxidation, DNA damage, and eventually cell death. And examples of that include paraquat through involvement of dopaminergic neurons and the alcoholic exposure in the chronic type. There's also the possibility of excitotoxicity, and the main effector of that would be glutamate for the most part. There are some agents that either the agent itself or their metabolites can bind to these glutamatergic receptors and cause excitotoxic cell death through that pathway. Cocaine has also been said to enhance glutamate release and participate in this mechanism. There are other ways to disrupt cellular signaling. It could include DNA damage, for example, as well as cytoskeletal protein interference with cytoskeletal proteins functions, or synaptic function in this case. And some examples include some antineoplastic drugs and some heavy metals. Like, for example, calcium, they kind of interfere with calcium signaling. Most of what I said so far is are agents that involve the neurons for the majority of examples. Now we're going to talk about potentially other mechanisms. So there are toxins that will involve oligodendrocytes primarily rather than neurons. And some of those include solvents, for example, which can cause myelin damage, as well as some chemotherapeutic agents, such as methotrexate. Lastly, there can be an indirect effect or mechanism in which the toxin or the agent that we are talking about, it will induce T cell and microglial activation, that then will cause secondary damage to the CNS. In general, this is a reflection of what we were talking about, right? We're going to see that the damage to the brain can be specific to a certain cell type or a certain structure, such as myelin, for example. Damage can be also specific to certain anatomic locations that are particularly vulnerable to a specific toxin. And here's a table with an example of that. There are many potential toxic compounds that will cause bilateral necrosis of the basal ganglia, and they are listed here. In general, for the majority of neurotoxins, acute intoxication very frequently will manifest as diffuse cerebral edema. And lastly, there are a variety of toxins that affect the peripheral nervous system, and we are not going to talk about any of those today. Let's introduce some of these industrial and environmental agents. First, I wanted to talk about carbon monoxide. It is the most common known neurotoxic gas, and it is estimated that it causes about 450 accidental deaths annually in the US. The incidence in the rest of the world is also non-negligible. Typically, it is the exposure occurs in the home because of combustion of certain appliances that are incomplete and release these carbon monoxide. Once exposed, what it does systemically is that it prevents the binding of oxygen to hemoglobin, which in turn increases the metabolic demand and leads to mitochondrial injury, which is, as neuropathologists know, there are a variety of cells, particularly large neurons, that are susceptible to any increase in metabolic demand that is not met by the presence of oxygen. As I mentioned earlier, bilateral injury to the globus pallidus is very characteristic of carbon monoxide poisoning. And here are a couple of examples from the Ellison and Love book, in which you can see a relatively acute, hemorrhagic discoloration in this example here, versus a more remote injury in which there is necrosis of the bilateral pallidi. This can be relatively asymmetric. It doesn't have to always be symmetric as is the case in these examples. But that's not the only injury. You can also have evidence of white matter as well as other gray matter regions affected by carbon monoxide poisoning. Important to remember is that in the acute exposure phase, it is possible that the brain shows this distinct bright cherry red discoloration, but typically that is less frequent as hours go by. And a similar mechanism is what we experience with cyanide exposure. Cyanide binds to cytochrome oxidase, and so it prevents oxidative phosphorylation at the mitochondrial level with the same cytotoxic effect. It's important to know that cyanide inhalation can cause death in minutes. And those of you that may be in the forensic world or potentially in others might know that in some cases it might be important to take precautions if there is an autopsy on a known case of cyanide inhalation. Very few words on some heavy metals here. Aluminum can cause direct neuronal injury, and one of the most known effects was in the past where there was a aluminum accumulation with certain types of dialyses that are no longer used, and it caused these pretty severe encephalopathy syndrome. Neuropathologically, you can appreciate our gyrophilic deposits in neurons, but as I said, this is pretty much no longer in incidence in our environment. Arsenic can also be associated with some events of acute hemorrhagic leukoencephalopathy. And lead in the acute exposure can cause cerebral edema with vascular injury and necrosis. The peculiarity about mercury is that it can induce injury in small neurons, including the cerebellar granular cells and other granular cells in the cortices, in addition to accumulate in neurons and glial cells whenever we have long-term survivors. So I acknowledge that this is a very short and not very detailed description of all the potential effects of these. So I invite you to explore more if you're interested. In the field of chemical toxins that we can be exposed to, I wanted to highlight just a couple of them. Methanol is known to cause a global hypoxic injury and characteristically bilateral hemorrhagic lesions of the putamen, as seen here in this gross image. I'll point out that it is not limited to the putamen, but it definitely includes those regions. Ethylene glycol is a very interesting toxin that will cause vascular injury with deposits of calcium oxalate crystals. And some solvents like toluene can cause injury by both the acute exposure, but in the chronic situation, for example, with the use of sniffing glue, can cause cerebellar atrophy. Let's talk about a case. So I didn't provide virtual slides for this talk, but I am going to sprinkle a few cases along the way to highlight some of the information. So this is a 22-year-old man that was known to use stimulants frequently, that presented with vomiting and then started becoming belligerent with family, eventually was found down, difficult to arouse, and developed seizures. When he was taken to the hospital, he admitted to having ingested something. And eventually the police found a half-empty can of antifreeze in the patient's home. Testing revealed severe metabolic acidosis, which proved resistant to treatment, and then the patient died. This is an autopsy in which the brain weighed 1,600 grams, so heavy and edematous. And microscopically, there was evidence of very prominent pericellular edema, neuronal injury, as well as perivascular edema with this deposits of proteinaceous material. But that is not all. With polarized light, you are able to identify brilliant birefringent calcium oxalate crystals. So this is an example of ethylene glycol inhalation, which can occur by ingestion of antifreeze that may contain methanol or ethylene glycol with similar catastrophic effects. For those interested, this is a case report in the New England Journal as a CPC in 1979. Let's move on to some recreational agents. Again, it's going to be relatively short. Ethanol is one of the most widely spread substance of use that can cause impairment and deterioration of the brain. Frequently, chronic alcohol use is associated with malnutrition and other medical disorders like liver dysfunction, for example, that I'm not going to address today. So some of the disorders that we might associate with alcohol in the brain are mediated by malnutrition, and so I am not going to mention them. In general, with pure, if we try to consider this pure alcohol-related brain damage, what we're going to find is diffuse atrophy. And characteristically, and an image is worth more than 1,000 words, very striking atrophy of the superior vermis, and which is underlined by loss of Purkinje cells that tends to be more prominent at the crests of the fovea rather than at the depths of the sulci. We could do a very long lecture on opioids, but I wanted to highlight that they are the leading cause of death by substance use. Of those, typically fentanyl and heroin are the causative agents. And the main mechanism is a central depression of the respiratory nuclei in the brainstem. Opioids there's a variety of chemical compounds, and there's a variety of potential ways of ingestion. And if there is survival and then death delayed after weeks, months, or whatever, typically in patients that are on a respirator for a long time, you can find, or is it possible that you will find the effects of hypoxic ischemic leukoencephalopathy. And I highlight leuko because in some cases you're going to see white matter injury in addition to the other classic effects of severe diffuse hypoxic ischemic injury that you're familiar with that may affect the basal ganglia, may affect the cortex with laminar necrosis, etc. In this case, also, there is significant dilatation of the ventricular system. So here's case number 2. In this case, we have a woman that had a history of polysubstance use, that had a history of epilepsy because of prior traumatic brain injury. She had a history of pulmonary embolism, hypertension, and developed some vomiting, and then that eventually progressed to some focality, neurological focality with hemiparesis, dysarthria, eventually confusion, and had to be sedated and intubated. At that time, the toxicology screen was negative, but the family members revealed that she had been using inhaled heroin in the days prior. Despite the initial improvement, she progressed and died eventually. And so we had an autopsy in which, in this low power view of a Loxol H&E, you can see that there is a relatively preserved cortical ribbon with an underlying white matter that is really disrupted, very distorted in color. So you can appreciate maybe that this preservation of the U fibers that stay blue, which is the normal appearance of myelin with this stain, whereas the majority of the white matter in view is abnormal. On closer look, we appreciated diffuse spongiform vacuolar white matter change. We could appreciate that there was reactive gliosis, axonal loss, and loss of oligodendrocytes. Here's an area that was relatively spared in this case, as I mentioned, with sparing of U fibers. And so this is a pattern that is characteristic of heroin inhalation leukoencephalopathy, which is also known as chasing the dragon. Stimulants like cocaine and amphetamines are associated more with cerebrovascular events in young adults, so in comparison of the typical epidemiology of cerebrovascular disease, which can usually be attributed to direct vasoconstriction of the effects of these compounds, which would lead to ischemic infarcts, occasionally with hemorrhagic transformation. They can also present with intraparenchymal or subarachnoid hemorrhage due to the sudden increase in the blood pressure that these compounds can cause. And it is said that in cases that present with hemorrhage after use of cocaine, about 50% had underlying lesions, such as arteriovenous malformations, for example, or aneurysms. Other potential mechanisms that have been described include embolism from cardiac arrhythmias, for example, and the potential for increased platelet aggregation that would be more inducive towards ischemic infarctions as well. That is all I had for the recreational agents. So we are now moving towards the effects of therapies in the CNS. This picture is just to highlight that I'm definitely not going to cover all of the potential examples of iatrogenic neuropathology. This is a coronal slice from a brain with a patient that had been on ECMO and developed a widespread acute hemorrhagic encephalopathy. And of course, the underlying mechanisms of that are much more complicated than just attributing it to one substance, for example. Starting with drugs that are not anti-neoplastic and that have known effects in the CNS, I wanted to mention phenytoin. This is an anti-epileptic agent that has been used in the past very frequently and for long periods of time. But it is known to cause this cerebellar toxicity with loss of Purkinje cells, as well as granular cells with development of Bergman gliosis. In these images, you can see that at the microscopic level, as well as macroscopically, there is diffuse atrophy of the cerebellar folia, including at the vermis and the hemispheres, different from what we saw in the cerebellum affected by alcohol, for example. I'd say that this is one of the potentially known as like old school drugs. So it is no longer very popular in use for patients with epilepsy. So we don't really get to see these toxicities much. A word on calcineurin inhibitors. What are those? They are immunosuppressants that are used to prevent transplant rejection and to treat autoimmune inflammatory disorders. Examples that you might be familiar with are cyclosporin and tacrolimus. So the very characteristic clinical syndrome for toxicity associated with these agents is called posterior reversible encephalopathy syndrome. And I highlight reversible in quotes because the reversibility of the changes sometimes is really not there, and patients do not fully recover from this injury. Typically, it's going to present with cortical blindness, for example, because it affects the radiations. And so there are also, if it also involves other areas of that, posterior occipital and parietal lobes, it can also develop alexia and agraphia, for example. The brain imaging will show the signal abnormalities in these locations. So it is not, however, limited to the posterior aspects of the brain. I should have probably quoted posterior in addition to reversible. Because there are cases in which similar changes are seen in other areas more anteriorly in the CNS. There are very few, so rare fatal cases, and here's an example of one that was published as one case as part of a series. And in those cases, what has been described is this injury to the white matter with evidence of endothelial damage and petechial microhemorrhages. Why did I use this plus here is to remind everyone that these findings are not exclusive to calcineurin inhibitors by far. These can be also seen in patients with malignant hypertension, but also with the use of other drugs, including chemotherapeutic drugs listed there, that can have a very similar both clinical and radiological and pathological picture. I wanted to bring this finding that I think, at least in our practice, is quite common, which is the blue brain that has been called in different publications by some of our colleagues as avatar brain or pistachio green brain. Methylene blue is used in a variety of settings, but the more important, I think, for our knowledge is that it's often used in therapy refractory shock. So many of our patients that come to clinical autopsy in our hospitals have been in terminal shock before. And so it is not uncommon that methylene blue has been used as part of the rescue pressors. It is thought that the effects on the brain are clinically innocuous. There was one report of methylene blue associated encephalopathy, and that was in a different setting in the use of methylene blue for parathyroid surgery, and I really didn't see a lot more descriptions after that. So what happens? The brain actually turns blue, and it is affected by exposure to air. So the understanding is that there has to be an oxidative step between the methylene blue that then becomes oxidated and blue. And I like this picture that highlighted that this part of the brain, the cut surface that has not been yet exposed to air for a long time, appears normal color, whereas the external surface appears blue. This change can be detectable as early as 24 hours after the administration of methylene blue and persists at least 48 hours after the fact. I have seen a real variety of intensity of these blue discoloration. Now to other things that truly both have changed our understanding of survival for patients with cancer, but also can be dangerous in terms of causing injury to the central nervous system. So injury with radiation it's not something to dismiss, because it can occur to up to 25% of patients that receive conventional doses of radiation. The cumulative doses listed there are typically a threshold under which we do not frequently see injury. So they're considered safe thresholds. The manifestations of radiation injury can occur at an acute or early delayed timing, so days, weeks, versus at a late delayed time. And the acute and early delayed is considered mostly transient and reversible, and it is attributed to dysfunction of the blood-brain barrier with some degree of cerebral edema. These are not usually fatal. Whereas when there is evidence of late toxicity, that is actually more describing in the underlying disorder. The underlying pathology includes radiation necrosis with direct injury to glia, neurons, and endothelium, the entirety of the tissue examined, and it's often irreversible. In that context, I think it's important to bring the concept of pseudoprogression, which basically refers clinically to patients that develop contrast-enhancing lesions that appear about 2 to 6 months after chemoradiation. So these are patients with high-grade gliomas, mostly glioblastomas. But those ring-enhancing lesions, if you follow them in time, they either improve or stabilize. However, as practicing neuropathologists, I'm sure most of you have encountered this situation in which a neuro-oncologist is trying to answer the question, is this new lesion in this patient recurrence of their tumor, or is it pseudoprogression or treatment-induced necrosis? So these are the things that you should be familiar with that will help you determine that the amount of recurrence of the tumor is not the main part of the lesion. So here are descriptions of those things. So for example, you're going to see infarct-like zones of necrosis, which frequently are associated with dystrophic calcifications. And these are also described sometimes as bland necrosis. The blood vessels suffer a variety of changes, including hyalinization, fibrinoid necrosis, telangiectasia proliferation, etc. The brain parenchyma that is adjacent to the lesion could be pale gliotic, and all of these vascular changes can occur within the areas of necrosis as well as beyond that area. Radiation-induced atypia is not such a prominent headache producer in neuropathology as it can be in other specialties in pathology. But you can find bizarre nuclei in cells that are otherwise not neoplastic. It can also induce changes to tumors that make them non-recognizable anymore. For example, an oligodendroglioma might look like more like an astrocytoma in the context of radiation-induced atypia. And then lastly, even though these lesions can be cellular, because they can be gliosis, they can be some inflammatory elements, typically there are no or rare mitoses and a low proliferation rate. A few examples of long-term sequelae, again, that we're not going to spend a lot of time describing, include vascular malformation-like lesions. Our clinicians, in my experience, still like to call them cavernomas. And they refer to, predominantly, we see them in children that receive radiation for brain tumors and then, survive and continue their life into their adulthood, and then over time can develop these hemorrhagic appearing lesions. There's a very rare, unique syndrome that the name is very descriptive, stroke-like migraines attacks after radiation therapy. It is also attributed to vascular injury, although there is not a lot of data that in these cases, because frequently these are diagnosed radiologically, since the MRI is really characteristic with changes of exclusively the cortical ribbon in the areas involved. There is also radiation-induced leukoencephalopathy. This can be a quite devastating disease that affects many parts of the brain, and it's typically historically has been secondary to whole brain irradiation. So it's another example of something that is currently rare in our practice. Lastly, just a mention of radiation-induced neoplasms that can occur and typically happen many years after the initial insult, and can include meningiomas, gliomas, etc. Here is a gross image of a brain from the patient with radiation-induced leukoencephalopathy. It demonstrates very large and confluent areas of chalky, white, friable appearing lesions that can also suffer discoloration. And then, again, that mostly affect white matter. And microscopically, there's evidence of this coagulative type necrosis with many vascular changes, including fibrinoid necrosis, hyalinization, etc. I wanted to highlight that now there are also other, examples in which radiotherapy can affect the adjacent brain. This was a case that our neurosurgeons found particularly interesting, of a patient with a anaplastic meningioma that recurred a couple of times. These are just imaging over time. And at one point was treated with brachytherapy seeds in the site of surgery. When this patient needed a third surgery because of another recurrence, the neurosurgeons were using intraoperatively 5-ALA to guide the resection. And it showed bright lighting, light fluorescence in the tumor itself, which is very characteristic of cellular tumors and proliferative ones. But they also noted that there was an area of the adjacent brain that also seemed to bright under the scope. And so they biopsied that, and what we were able to find was just simply inflammation. So abundant CD3 positive T cells as well as CD8 positive macrophages. Now, whether that is directly caused by the radiation from the brachytherapy versus the fact that this is a site of prior surgery, I think it's really difficult and challenging to separate. But the main point was that you can have 5-ALA positive regions that are not tuned. We're moving on now to chemotherapies. Chemotherapy can affect the brain in a variety of ways. And of course, like with everything, you can have secondary effects from systemic use of agents. But also, in this example, you can also have direct effect when chemotherapy is administered locally, meaning intrathecally. The developing and the aging nervous systems are more vulnerable to toxicity from chemotherapy, which I think it can probably be said about pretty much every toxin, and I didn't emphasize that earlier. Methotrexate is probably the best known and studied agents, but a variety of chemotherapeutic substances will cause predominantly white matter toxicity. As mentioned earlier with other things, so for example, there is a synergistic effect whenever there's combinations of therapy, and also a combination of, for example, radiation and chemotherapy simultaneously. I wanted to mention the so-called chemo brain, which is a very studied condition in which patients experience a cognitive dysfunction that is chemotherapy induced, that is usually mild and considered reversible, but in some patients it can be quite limiting. There's not a lot of data to really talk in depth about neuropathology, but it's important to mention that this is a very significant sequela that our patients may experience. It is thought that the effects, adverse effect of chemotherapy in the brain includes disruption of neurogenesis, gliogenesis, as well as myelin integrity. And here is our case number 3. This was a 5-month-old baby with ALL that was treated with chemotherapy that included methotrexate with good results initially. However, over time, she developed involvement of the CNS, as is well known to occur with this disease, and eventually was treated again with methotrexate that included intrathecal administration. 3 more times after initial response, she developed CNS relapse and eventually was treated, in addition to increasing doses of methotrexate, other agents, radiation was also administered. Eventually, over several months, she developed a variety of neurological symptoms and died at age 6. In the gross images, this is the I was trying to find, this is a case from 1981. I was trying to find gross images, and the only one I found was this. And then I realized that this was actually the one that is in the Ellison and Love book, thanks to Dr. Hedley White. So anyway, to emphasize that the changes are in the white matter, and they are these confluent irregular lesions with varying degree of discoloration, yellow to orange, that appear friable. And microscopically, we could describe them as irregular lesions that come with myelin pallor, as well as vacuolization. And then I'm going to, this is a section of cortex from the occipital lobe. And you can see this is the predominant lesion here, but I would also highlight that there are other regions in which it is less prominent, but also present, that there are changes occurring. These changes initially are just this vacuolization of the white matter with a lack of associated inflammation that can be quite striking. However, in the areas of more of necrosis, you can see this disruption of the neuropil with necrotic appearance. In some cases, you can see adjacent reactive gliosis with this plumb prominent reactive astrocytes. And occasionally, these axons that are dilated and prominent can become calcified. So these are all the findings characteristic of methotrexate-related multifocal necrotizing leukoencephalopathy. And I mentioned methotrexate-related because in this case, there's very possibly a synergistic effect from the fact that the patient received radiation. They are characterized as these multiple foci of white matter injury that can become confluent in different locations, mostly affects the cerebral white matter, but as in this case, it can also affect posterior fossa structures. The histology is this prominent spongiosis and necrosis with oligodendrocyte loss, and particularly markedly swollen axons, which is thought to be more specific to the effects of methotrexate rather than the radiation-induced leukoencephalopathy with that coagulative type necrosis that we have seen. And lastly, microcalcifications as known. Our last area is going to involve immunotherapies. Immunotherapies, as many of you are familiar with, have revolutionized the environment of cancer care in many specific and in also non-specific treatments of a variety of cancers. The main protagonists of this revolution are immune checkpoint inhibitors. So immune checkpoint inhibitors are molecules that interfere with two different systems of control of regulation of T cell activation. In the lymph node, or so also known as early T cell activation, CTLA-4 is the main mediator, as well as opposed to in the peripheral tissues, in which PD-1 signaling is the responsible for this control of T cell activation. So how does it work? A T cell has a T cell receptor. It's going to detect a signal on a dendritic cell, and the presence of CTLA-4 in the T cell that is then bound to the ligand on the other cell is going to stop that activation of the T cells. We have antibodies that bind to CTLA-4 and interfere or interrupt this blockage, allowing for the second signal mediated by CD28 to activate T cell and induce proliferation and response. Similarly, at the PD-1, the ligand is PD-L1, and it is a more direct more direct inhibitory effect towards the action of the T cell receptor binding to the MHC molecules in either tumor cells or others. So we have agents that act against CTLA-4, the more best known is ipilimumab, and agents that interfere with the PD-1, PD-L1 signaling, most known are pembrolizumab or nivolumab, but now there's a variety of others available to our oncology events. I think that I like this figure from this paper because it highlights that once this occurs, then then the secondary effect is that T cells are going to become activated. They're going to work with CD4 T cells as well as macrophages to induce their damage. So when that happens in the tumor, which is the target, then that's exactly what we were wanting to do with the therapy. However, that can also interfere with other non-tumor sites. Specifically, in this case, we're talking about the nervous system, and that can induce cytotoxic mediated injury of the neurons directly. And in some cases, that neuronal death can lead to the release of neural antigens that can also be part of the system of increased indirect presence of autoantibodies. So what happens? What happens is that whenever a patient receives immune checkpoint inhibitors, they can develop what's called immune-related adverse events. As I mentioned, these are on-target toxicities, but off-tumor, so overall off-target, that may affect any organ system. And some of the mechanisms are listed here, and I mentioned them, but I think it's important to emphasize that what can occur is either an exacerbation of a prior autoimmune condition or the development of a novel autoimmune response. And so it is important in our clinical environment to know that sometimes whether the patient had a paraneoplastic syndrome and it was elicited then became clinically noticeable by the presence of immune checkpoint inhibitors versus it's a patient that would never had a paraneoplastic syndrome, but the administration of this it triggered that autoimmune encephalitis, for example. It's going to be something that is probably not known in most cases unless we screen for autoantibodies in patients with a variety of oncologic disorders before administering immune checkpoint inhibitors.
Dr. Martinez-Lage, we're a little less than 15 minutes away from the top of the hour.
Sounds good. Thank you so much. So in terms of the incidence of these, I mentioned that most patients were going to suffer one or more immune-related adverse events. But in terms of neurological and severe immune-related adverse events, they are relatively rare. Only about 1.5% of patients, and this is just a description of our series from Mass General Hospital, will develop severe neurological syndromes. And it's important to point out that the majority of them are going to include peripheral nervous system involvement in the form of neuropathy, but also myositis or myasthenia. And these three take the majority of the immune-related adverse events that affect the neurological systems, whereas involvement of the CNS is much more rare. Here's another case. This patient was 71 and was diagnosed with melanoma, was treated, and everything was fine. And then 3 years later, he developed metastatic disease. And at that time, he started treatment with pembrolizumab, which occurred. And after 3 cycles, he developed a subacute progressive encephalopathy that eventually was very symptomatic and severe with akinetic mutism. And at the same time, they also had symptoms of peripheral neuropathy. The clinical team stopped the immune checkpoint inhibitor and provided empiric treatment with steroids and IVIG to try to stabilize this autoimmune condition or assumed autoimmune condition. But there was no definitive improvement, and so they obtained a brain biopsy. And what we saw in that biopsy was a hypercellular brain cortex that seemed to have a variety of small cells that, when highlighted with immunohistochemistry, showed a significant amount of CD3 positive T cells involving predominantly in the cortical areas that were not limited to the perivascular spaces, but also spilling into the parenchyma, and associated with a pretty significant evidence of gliosis. So in this case, this patient had evidence of an autoimmune-mediated or immune-mediated encephalitis or encephalitic process. Out of curiosity at the time, we performed this double staining that we use for our lung cancer patients. And I think it was important to highlight that there was no diffuse expression of PD-L1 in the brain. Again, this was the early days of immune checkpoint inhibitor use in clinical practice. But there is some low level of expression in microglia, and I think that's what we're seeing here in some of these clusters of microglial to lymphocytic interaction. And this is just out of curiosity. The last topic is the last topic in immunotherapy is the use of adaptive cell therapies. There's a variety of them, and I have listed them here, but for the most part, what we are hearing and what we are seeing in our patients is the use of chimeric antigen receptor T-cell therapy or CAR T-cell therapy. It consists on manipulating the patient's lymphocytes to use their T-cell receptors and direct them against a particular antigen. And so what the extracellular domain that is engineered into these cells is specific to an antigen. And then the intracellular domains can also be manipulated to induce better stimulation or additional signaling pathways downstream. So there are several generations of CAR. The target antigens that are most commonly used and in routine practice now are predominantly for B-cell neoplasms. CD19 is by far the most common. CD22 is also used in a particular type of B-cell leukemia. And there is also a BCMA-directed CAR that is used in the treatment of multiple myeloma. We should mention that there are a number of studies looking at the use of CAR T cells in brain tumors specifically, whether it's CD19 directed in patients with primary or secondary CNS lymphoma, or a variety of different antigens in high-grade gliomas. The overall toxicity, and again, this is mostly referring to the B-cell neoplasms, revealed that there's cytokine release syndrome in a large number of patients. And initially, neurotoxicity was described in anywhere from 40 to 67% of, and these are all from published major trials. I thought it was interesting that it was specifically commented in that paper that neither CRS nor neurotoxicity were predicted by animal modeling before clinical translation. I think highlighting how the tools that we have at hand are extremely useful, but are still limited when we are translating our understanding of disorders and of therapies from the lab into the clinic. So the effects of the infusion of CAR T in a patient that cause neurological symptoms is known as immune effector cell-associated neurotoxicity syndrome, or ICANS. And it presents with a very stereotyped pattern of neurological symptoms, including aphasia as a very prominent one. It's important that it happens within days of the infusion. The majority of patients also suffer from cytokine release syndrome, which is a systemic disorder with high fevers and sometimes respiratory compromise. The real-world data shows that 15 to 30% of patients that receive CD19 CAR T cells are going to suffer from ICANS, from a variety of grades, from 1 in which the patient is mildly disoriented to grade 4 in which they are unarousable. There have been some reports of fatal ICANS, but it is a very small percentage of these patients. This was a particularly dramatic case in which cerebral edema developed hours after the infusion. And this was in some of the early trials. And my understanding is that product was stopped from being studied after this case, in which you can see there was really serious diffuse edema. And my colleagues at Brigham and Women's Hospital were able to demonstrate injury to the vessels with fibrin deposition and plasmatodendrosis with GFAP, with this beaded disruption of all of the astrocytes, with very limited to no inflammation involved. This is the result of the CAR T cells doing what they're supposed to do, which is activate macrophages and continue the inflammatory response to attack tumor cells. But in that process, cytokines are released, including interleukin 1 and 6 and GM-CSF, that are known to affect and develop CRS and neurotoxicity. Thankfully, there are now different treatment methods that can effectively treat these patients and make them survive through the CRS and their ICANS. When we treat tumors that are in the brain with CAR T cells, then we can develop something that's called TIAN, or tumor inflammation associated neurotoxicity. Basically, in this case, the effect of the CAR T cells in the tumor proper create a situation of edema and increased inflammation that can also lead to to typically recurrence of the symptoms that the patient had because of the location of the tumor, and or more diffuse symptomatology. But wait, there's more. The last thing that we've been learning about is that when patients survive for months, they can also develop some neurotoxicities. And in this case, this patient developed what's known as a motor and neurocognitive disorder that was in the context of BCMA-targeted CAR T cells that are used for the treatment of myeloma. Neuropathology has shown predominantly just a significant amount of gliosis in the basal ganglia, and the presentation includes Parkinsonian-like syndromes. There is the understanding that potentially there is a low-level expression of this antigen, which was thought to be B-cell specific, in the striatum. Lastly, I wanted to point out that temporal correlation is not causation. So in this case, we highlighted that even though this patient developed neurotoxicity after receiving CAR T cells, the pattern of neuropathology and MRI was more consistent with a fluid arterine-associated leukoencephalopathy rather than something driven by the CAR T cells. So thank you so much. And I will.
Thank you, Maria. That was
sharing.
awesome. At this time, we'll move into Q&A. You may submit your questions via the chat box, or you can unmute to ask a question. When you're submitting via the chat box, please ensure the message is to everyone so that we can all see what you're asking. To unmute, select the microphone in the lower left corner, and after you've asked your question, please remute to avoid background noise.
Thank you. I'm reading the chat quickly, and I appreciate those that contributed with information. So thank you so much, Kelly, and thank you so much, Mark. I did notice your question, Dr. Mark Delvideo. Do you have any thoughts about the hypothetical risks of micro and nanoplastics particle toxicity? And I explicitly intended initially to talk about that in this talk, but then eventually I realized that really the data, the hard data is really very limited. And I think we're going to know a lot more about how the amount of microplastics that are in our bodies and in our brains are affecting our function. Oh, and B. Lopez shared an article that demonstrates the presence of these in the brain. Let's see, Sandra Camila Paragua is asking that for radiation toxicity, the cumulative dose is lifetime or for a period of time, 10 years or so. My understanding is that that is a lifetime limitation, but I might be wrong. So yeah, I cannot say that with certainty. I'm sorry. So let me go back and then, because we have a few more minutes, share the knowledge that was shared with us. So Kelly Mrachek told us that aluminum can be detected in tissue using the Morin stain under immunofluorescence. That he's used it to diagnose aluminum-containing macrophages in macrophagic myofasciitis, and shared a link to the paper as well. Thank you. Similarly, Mark Delvideo shares that in terms of toluene, he has seen over 100 autopsy cases of persons who inhale toluene. I might be pronouncing that wrong, I'm sorry. Usually as a pain thinner solvent for intoxication. The most common pathology is patchy demyelination with perivascular macrophages that contain birefringent crystalline inclusions, and also share the citation for that paper. He also brings up that the anti-epileptic drug vigabatrin can cause a vacuolar myelinopathy that might be reversible. Dr. Gogden mentioned that radioactive beads implanted in the tumor could be a hazard during autopsy. Good point, yes. Okay, well, I really appreciate everybody's contribution. Thank you for sharing the knowledge, and thank you for your questions.
Thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PathLMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Martinez-Lage for an excellent presentation. This concludes the session for today.